Hello, everyone, and welcome to our capstone presentation for the PlanItSister support management tool. We would like to begin our presentation with a territorial acknowledgement. We acknowledge that we learn, work, and play on the unceded traditional Coast Salish lands, including the Tsleil-Waututh, Squamish, Musqueam, and Coquitlam nations. Our team name is PlanIt People, and our team consists of myself, Niru, Hafsa, Ravina, and Michael. We all are members of the BIPOC community and are all passionate about raising awareness about the current overdose crisis and reducing barriers and stigma for people who use drugs.
So our project focuses on the gender-specific barriers that women who use drugs face when accessing overdose prevention sites and safe consumption sites in BC. This leads us to our guiding problem statement, which is, how might we tailor current overdose prevention sites and supervised consumption site services to overcome the specific gendered barriers that women who use drugs face when accessing these services in BC? For the duration of the presentation, when we refer to women who use drugs, this is inclusive of all women, non-binary people, and transgender women who reside in BC and who require services. This program is tailored to women who use drugs. However, we would not turn away any woman, non-binary person, or transgender woman who may require the offered services. Since before the COVID-19 pandemic, BC was still in the depths of the overdose crisis, which started in 2016. This dual pandemic has observed an increase from 17.3 to 35.4 deaths per 100,000 people when comparing data from 2019 to data from 2020 and 2021. Research has continued to demonstrate the efforts of safe consumption sites and overdose prevention sites in reducing these drug-related harms. This is done through allowing individuals to inject, snort, or swallow drugs in a monitored setting, providing sterile equipment and Narcan, drug checking, and basic medical care. Canada's first safe consumption site opened in 2003 in Vancouver's downtown east side, and currently there is only one women-only site in all of Canada called Sister Space. Although statistics do indicate that men continue to use safe consumption sites more than women, as indicated by the 73% men to 27% women ratio of Insight's population, we have decided to target women who use drugs, as we know that they face specific gendered barriers when they access these services.
So we used the equity-centered design framework for this project. We began with the notice stage and worked our way to the reflect stage. However, this was an iterative and reflective process. We acknowledge that in the real-world scenario, we would be continuously working through these steps. During the notice stage, we developed an emotional and self-awareness of our own identities, biases, and assumptions. During this stage, we are assuming that there are current gaps in the existing services offered for women who use drugs. The government's focus on the opioid crisis has been neglected due to the COVID-19 pandemic, and also there is enough existing research to support our data collection. For biases, we felt that we understood the needs of the BIPOC community, as our group consists of 1 cis Black male and 3 cis women of color. We also thought that as healthcare providers and outreach workers, we understand our biases and assumptions about women who use drugs. We also felt that we understand the needs of women because we have 3 women in our group. Overall, we have implicit socioeconomic, racial, gendered, ableist, and other biases that we must continuously reflect on in order to create an equitable design. So we moved on to the empathy stage, where we imagined ourselves in the shoes of our end users to gain a deeper understanding of their situation and what they really go through. After gathering all the relevant information, we created a fictional character called Jennifer for our empathy map. Some of the main themes that stood out during this stage were the fact that Jennifer felt confused, anxious, vulnerable, and misunderstood. Jennifer also hears stigmatizing language, cultural backlash, and people yelling. Jennifer sees the male abusers, the police, and people dying of overdose. Some of her pains included fear of overdose, violence against women, and suicidal ideations. Jennifer wants to gain a support network and build sustainable relationships.
After initial feedback sessions and reading key literature, we were able to complete our root cause analysis. In this, we identified 6 main barriers that women face when accessing OPS and SES sites, which were 1, a lack of safe space due to stigma felt by staff, harassment by men present, cultural and language barriers, and non-gender specific services available at these sites. 2, gender-based issues such as gender norms or roles, violence against women, male-dominated services, sexism, and sex work. 3, mental health issues that were influenced by various types of trauma, violence, a lack of diagnoses for existing conditions and their substance use disorder. 4, structural and social barriers built from the social determinants of health, systemic stigmatization, legal and government structures, and a lack of research on these specific issues. 5, sex-based issues such as the physiological needs for assisted injection due to vein size, biological susceptibility to addiction, higher likelihood of overdose due to lower drug tolerance, and other physical health issues associated with sex. And finally, 6, child welfare and pregnancy-related barriers that stem from fear of stigma, distrust in the healthcare system, and the biases that healthcare workers carry. Lack of childcare services available for women who use drugs, and pregnancy-specific issues that women who use drugs encounter. This root cause analysis informed our 3 policy ideas. The first idea was an expansion of the wraparound service centers for women who use drugs. Stakeholders identified that expanding the service across BC was necessary. However, it's expensive to fund and therefore difficult to implement. The second was a peer mentorship toolkit and system for pregnant women or mothers who use drugs. Stakeholder feedback informed us that although this would be extremely helpful for many women who use drugs in this demographic, there would be barriers related to existing child welfare policies that would incite fear in women accessing these services. We therefore decided on our final idea, which was an individualized support management tool for addressing a woman's specific service needs. Our stakeholders liked this idea because of the flexibility, adaptability, and accessibility of this service. Barriers identified and suggestions made by stakeholders were accounted for when creating our prototype.
For our initial prototype, our group decided to go with the storyboard format. We'll quickly be going through the storyboard this time around, as we will revisit it when we show you our final prototype. Our service consists of an individual assessment tool and our intake form that can be used to create individualized case plans to address the specific service needs women who use drugs are requiring. Essentially, the service will work through a self-referral process where an individual can refer themselves by walking in, phoning, or using other social media platforms. Once they refer themselves, they would be provided with an intake form where they would tick off the services they are requiring. Our hope would be that this prototype would be piloted at Sister Space, and eventually down the line, we would like to incorporate this project as a pop-up shop style service at other OPS and SCS sites as well. Here is an image of our initial intake form. Our initial idea was that women would go through this form, fill it out, and tick off what they are requiring and hand it back in once they are finished. Feel free to pause at this time to get a good read-through of the form. After that, these individuals would be contacted by a case manager who would delve further into what their needs are. The case manager would also assess with the client what their main priorities are and work with them to finding solutions to these concerns. We also created a resource document that can be utilized by the case manager to work and service users on a specific issue or connect them to a service. This document accounts for a number of services ranging from getting identification documents to employment and income assistance. This would be a working document as services are constantly changing. After working with the case manager and identifying issues, individuals would be linked with their own personal care team, who would work towards reaching the client's goals.
So the stakeholders that we consulted consisted of a broad range of individuals, which included service providers, experts in the field, advocates, drug policymakers, and researchers. And here's a list of organizations that many of them belonged to. We've compiled some of our feedback that we received from the stakeholders. The main suggestions that we received facilitated the change in our prototype were removing the use of the word form and case manager, as it can be seen as intimidating to the client population that we are targeting, using a smile scale instead of tick boxes, eliminating stigmatizing language from the assessment form, such as substance use and disorder, and finally, to add an Indigenous peer or elder into the co-located support team, as 82% of Sister Space users are currently identified as Indigenous. So now we're going to go through a storyboard of how the PlanItSister support management tool would work. And we created the storyboard using Jennifer from our empathy map.
I have so many needs, but I don't even know where to start. I'm hungry and cold and have this wound that I think is infected. It's impossible to figure out where to go.
I hear that they're providing tailored services down at Atira's Sister Space. Why don't you see if they can help you?
I was going to go and use the OPS service there anyways. I wonder if they can help with all those things though.
How can I help you today?
Hi, I heard about your individualized support program.
Wonderful. Here is our PlanItSister assessment tool.
Thank you.
This would be a guided conversation. We can write down whatever demographic information you feel comfortable including into the form. I will need to write an alias, method of contact, and your needs assessment down, however. Is that okay?
Okay, thanks. I would rather leave my address out of the form.
So using the feedback from our stakeholders, we adjusted the language in the intake form. A peer support worker would also go through the form with these individuals. This was suggested due to varying literacy levels in our targeted population. So this is our updated form. Feel free to pause in order to take a closer look at the form. You can see the changes made on this form based on the stakeholder feedback described earlier. We also changed the name of the care team from a case management team to a co-located support team. We will now continue with the role play of how our support management tool works.
Jennifer and her peer advocate support worker discuss in detail what the priority of her needs are. Hi, Jennifer. I hear and see that you are ready to take some steps to gaining housing. I'd like to help support you with this transition. I will be your peer advocate support worker. The peer advocate would connect Jennifer to co-located support team members of her choice, including a nurse, Indigenous elder or cultural leader, counselor, pharmacist, outreach worker, etc. The support worker can also use the working resource document at this point to locate resources for Jennifer. Let me introduce you to your care team.
6 months later, Jennifer's short-term housing goals have been met. She has been able to obtain her legal identification and documents, and she has ended up getting antibiotics to heal her infected wounds.
All right, Jennifer, you let us know if you need anything else down the road. We will keep your name on file and you are welcome to connect with us on your own terms.
Thank you so much. So in terms of reflection, one thing our group realized was that low barrier, low threshold programs such as the PlanItSister program are needed in order to bridge the gaps currently existing in services for women who use drugs.
It's also surprising to learn that wraparound programs such as the one we are proposing do not currently exist in a long-term and expanded capacity.
We were encouraged to learn from our expert stakeholders that they're continuing to conduct valuable research on this topic with the goal of improving women's tailored services.
We also realized the specific service needs for pregnant women, mothers, Indigenous women, non-binary people, and transgender women who use drugs.
Some questions that we have for you are, is PlanItSister transferable to other overdose prevention sites or safe consumption sites? And number 2, can you think of any low barrier, cost-effective ways to implement a service such as this?
Thank you.
Thank you.
Thank you.
And then these are our references. We also, for our storyboard, we used storyboardthat.com.